on bringing medications into the clinic. Many factors account to it. One of them is cost, but they have not been very successful at all. There are other areas where medications, they have been able to get investments back, like cardiovascular disease. But psychotherapeutics has been an area that many of the pharma are starting to cut. And that's why I brought it up, because I think that we all as a country are going to lose enormously if that continues to happen, if we don't contain it.
Well, my point would be, you get Office of Management and Budget, and they look at this bill, they see we're on the hook for everybody with neurological disorders. The cost for Alzheimer's is going to skyrocket. We're all paying for it. Autism, skyrocket. Parkinson's, epilepsy, and now the veterans population with TBI and PTSD, we're on the hook as Uncle Sam, big time. We had better invest, or else we're going to be paying through the back end. So it's going to pay for us as a government to step up and do the down payment on research on neuroscience, or else we're going to be paying through the back end. And this is where we need the IOM to say to the federal government, here's a way out. If we're going to have cost-effective, comparative effective analysis in this bill, here's where it counts. Comparative effective analysis shows if we research this stuff here, we're going to get interventions that are going to make a huge difference in just putting off the onset of Alzheimer's, mitigating the impact of autism, mitigating the impact of schizophrenia, allowing these vets, which we're already able to do, to repair spinal cords so they can get out of their wheelchairs and get into society. And, for us not to think big and think that the addiction field is there with Alzheimer's, autism, and all the rest, think as one mind with the brain and not think big. Pharma's going to come if we get one picture on this in the vision. I think so. I think if you define it that a neuroscientist gave me one more year with my dad. Neuroscientist is going to give a family with Alzheimer's, bring the memory back for their loved one. A neuroscientist is going to help a family with a kid with autism or Parkinson's, or schizophrenia, to not have to worry as much while that child grows up about them being marginalized in society. They're our first responders in this war on the biggest burden of illness, which is neurological disorders. They're going to set us free. These neuroscientists are going to go in there and they're going to set us free. First and foremost, our veterans. If we can't get that message across, we don't deserve to be in our business. This is it. This is going to save people's lives in huge ways. We're in the weeds here. We're in the weeds right now.
I agree, and that's one of the reasons why I'm very grateful to be here and being able to present the obstacles that we are facing. And I will definitively, since the meeting is ongoing right now at the IOM, highlight your point and your request that the IOM come up with very specific points and that can be used to guide how to revert these changes that we're seeing in the pharmaceutical companies. And I will also, for the record, be willing to provide the committee with the information regarding the disinvestment, the decrease in investments from pharmaceutical industry for psychotherapeutics. I think we need to be aware of this.
I'd like to finally just get that answer on functional reimbursement for people with neurological disorders in this parity bill. You all at ONDCP, at NIH, the experts in the field have to weigh in with HHS. The comment period's still open. If we don't reimburse for continued support for chronic illnesses, addiction's one of them, but all the others that I just mentioned are also them, we're missing the change from sick care to health care. We're missing a big opportunity.
I would just add that historically you got a terrific precedent on your side. As I was around when the first addiction treatment system was developed, and it was developed to treat the then opiate problems of returning veterans from a foreign war. If that hadn't happened, there would have been no political will to create that system. Well, we need to advance beyond that, as you have said. The science is there. I think I agree with you. Absolutely, veterans need to have the same kind of care for their neurological and behavioral problems that they have for their cardiovascular problems. Now they don't. If we follow our strategy, if we vigorously defend parity and vigorously implement the health care reform, they will have that chance.
I think one of the things that gentleman's question brings up is where are we with respect to non-narcotic, non-addictive pain relief? I thank the gentleman for his questions. I am going to recognize Ms. Watson if she would like to. Okay, I just have. I'll take my 5 minutes right now. Dr. McClellan, we heard from Dr. Velkov that it's cost-effective to treat prisoners with medications while in prison and before release to prevent relapse and recidivism. Does the administration have plans to expand access to medications in the criminal justice system?
Yes. We have plans to expand that access in prisons, but also in community for individuals who jointly have criminal justice problems that are associated with their addiction, as well as the addiction itself. So we don't just want to do it in jails or in prisons. We want to do it for people who are under parole and probation. We want to do it for people who are reentering. And yes, there are provisions through the National Institute of Justice and building upon the evidence-based behavioral interventions, but also the medications that Dr. Volkov spoke of.
Thank you. Dr. Volkov, in terms of neural research, once pathways are developed through addiction and a person kicks their habit, do those pathways still exist as in a way that can inform other types of repetitive behaviors that are not necessarily that are in effect that are a side effect, notwithstanding their kicking their drug habit?
And that's actually a very important question. And many investigators have tried to address the concept, well, how long do the brain changes last after you stop taking the drug? And if they do not revert back to normal, what are the consequences on behavior, which is one of, I think, your very specific question. What research shows is that there is significant variability in terms of the ability of the human brain to recover. In some cases, you see almost complete biochemical recovery of the abnormalities, and in others, you don't. And when you don't see the recovery, what you do see is derangement and an increased reactivity to stress on people that have been addicted to drugs, even years after they've stopped taking them. And this, of course, puts them at much greater risk to relapse, because if they encounter an adverse situation, like losing their job or losing losing someone they love, that is a period of great risk for relapse because of the enhanced sensitivity to stress that was developed from the chronic use of drugs.
In the case of alcohol abuse, someone who is a long-term alcoholic can develop what's known as an encephalopathy that is really an organic change in the brain. What does the research show about about parallel organic brain syndromes with respect to drug addiction and the and the ability of the human brain to recover?
Well, there are differences among the drugs. Some of the drugs are more toxic than others. Among the most toxic drugs, we have methamphetamine. Methamphetamine, with repeated use, can produce damage of cells, like the dopamine cells, that are very important in your ability to perceive pleasure and excitement. So the repeated use of these drugs can lead individuals, even years after they've stopped taking the drug, with a lack of excitement, with what we call in psychiatry anhedonia, the ability to perceive pleasure, with a lack of motivation.
What about cocaine addiction? What's the physiology in terms of cocaine addiction, and what damage is done?
The damage from cocaine comes from an effect of cocaine on blood vessels. It is a vasoconstrictor, and that means it decreases the flow to your heart, it decreases the flow to the brain. And that's why we started to see myocardial infarcts in young people when they were taking cocaine. But that also happens in your brain. When that happens,
long-term effect.
When you have damage from lack of blood into your brain, that can be long-lasting. And if the cells are dead, there's no way that you can actually bring them back. What you can do is
What about behavioral effects?
Behavioral effects.
Long term.
With cocaine, if you have a stroke in the motor areas of the brain, that will leave you paralyzed, and you will not necessarily recover your full motion. If you have it in the back of your head where you see vision, that could leave you blind. If you have it in an area that's involved with more silence type of behaviors like thinking, that will lead to disruption in thinking. So it's a matter, almost like a roulette. Where do you have the stroke in your brain that's produced from the effect of cocaine? That will lead to the symptoms. There is recovery, though, and we know that the adult brain can recover even from strokes. And what happens is that rest of the brain can take over. The younger you are, the better your prognosis, because your brain is more plastic. But the adult brain can still recover by engaging other areas of the brain to take that activity. So even with strokes from drug use, we expect recovery on those patients if they receive proper treatment.
And I'd like to add something that's less perceived but as insidious. People wonder why, after long periods of time, let's say an incarceration, a person would use a drug. Haven't they learned their lesson? Don't they realize drugs are bad? Don't tell me that it's brain changes that do that. And the answer is yes, it is brain changes. We know that cues that have been associated with drug use, people, places, things, have the ability not just to remind somebody about drug use, they have the ability to elicit the same changes as the drugs themselves in the brain. They light up, Dr. Volkoff's work has shown, they light up the same structures of the brain. They produce powerful craving even when you haven't used.
What do you mean they?
They is any stimulus that's been associated with drug use. I come out of jail. I haven't used cocaine for a long time. I run into Joey and Billy, the guys I used to use cocaine with. Not only do I know, because my mother told me so, these are not the guys to hang around with. That elicits powerful craving that you can show in an MRI. And that is part of the reason relapse rates are as high as they are. They are brain changes, behavioral changes brought about through learned associations.
We've heard of research where women who are pregnant, who are drug addicted, that it has an effect on the fetus, the child. Is that correct?
That's correct.
So would then pharmaceutical-related treatments block those receptors in the fetus or newborn as well?
Incredibly important question. Drugs of abuse enter the fetus brain, and psychotherapeutics will also enter the fetus brain. What we do not know sufficiently is the extent to which some of these psychotherapeutics could also be potentially harmful for the fetus. Take an example. nicotine replacement therapy for smoking cessation. On a woman that's pregnant, nicotine is teratogenic. It produces damage to the brain of the infant. If you give a nicotine replacement therapy, the nicotine will go into the fetus and affect it. So the handling of the substance abuser that's pregnant with medication is an area that requires specific research on any one given medication to ensure that we will not do damage.
Right. Let me conclude this panel with one question. It's kind of an obvious question. It may not get asked that often because it is so obvious. But I'd like to hear an answer from both of you. Why do we have this tremendous number of people who are on drugs? I mean, why? What's happened in our society? Why? I mean, you must ask yourself, even as you're trying to deal with the mechanics of treatment, why? What do you think? Why do we have this kind of widespread drug abuse?
I'd like to hear Tom's thoughts on this.
Boy, you are talking to the wrong guy. I've devoted my whole life to this, and my family is riddled with it, and I'm worried every moment of every day about my grandsons. Here is my answer. I'll tell you what I know, and I'll tell you what I think. What I know is drug use is different than drug addiction. Drug use is a function of availability, access, ease of availability, like any other attractive commodity. If you make more candy bars available, more people use candy bars. That is a fact. Second, another thing I know is that abuse and addiction is partially a function of genetics. We don't know how much, but we know that it contributes about the same amount of expression of illness as genetics contribute to the expression of diabetes, hypertension, and asthma. So when you have an extremely wealthy country that has an abundance of access to drugs of different types, of different varieties, you have more opportunities to use and more people who are using. Once that happens, the disease process, the disease of addiction, as well as the side effects of drunk driving and accidents and all the other sequelae of just simple use, take effect. That's why, as a guy who does treatment research my whole life, I don't want to just see treatment be the only answer to the drug problem. We need supply reduction as well as many more medications and much better prevention. That's everything I know. That's what I tell my grandkids right there. So,
Dr. Velkov?
Yeah, no, and I think that there are many reasons that why we have people end up taking drugs and becoming addicted. The issue of availability is a crucial factor. The more a substance is available, the more the probability that kids will start using it. And the younger you start using drugs, right, the greater your risk to become addicted. That's number one. Number two, we also, of course, recognize the issue of genetics. So if you come from a family where there is a history of addiction, which I also have in my family, then you are more vulnerable to become addicted. Three, there's another factor that we know that contributes, and that's almost any type of mental disorder will increase your vulnerability to taking drugs, and that can be depression, anxiety, schizophrenia, attention deficit disorder. Why? Because you may then use the medication, the drug, not just to get high, but to feel better. And in fact, in this country, for example, those that remain as smokers, there is a great overrepresentation of individuals with mental illness. So a mental disorder will put you at greater risk. So those are three factors that are biologically that will increase your vulnerability. Now, why is it, if it is genetic, and this is a more basic question, why is it that those genes remain if they have these adverse negative consequences? And of course, that's a very fascinating question with respect to why is it that some people become compulsive users and cannot stop it? That plays to basic understanding about how the brain creates memories, how some people can learn faster than others. Well, that may come to a certain price. So this plasticity of the brain is one of the factors that contributes to that vulnerability of addiction. But that plasticity also is extraordinarily important in allowing us to learn.
You know, this has been a very important discussion, and I saw Mr. Cummings came back, and Ms. Watson has not asked questions this round. Before we dismiss this panel, do you, Madam, have a question?
Could you yield for just a moment?
Well, I will, and also
yes.
Mr. Cummings, because I
Yes.
just there are questions that are very deep here, and I just want to make sure that the members of Congress who are present have a chance. We're about to dismiss this panel, but before we do you have a final question?
Coincidentally, I have an appointment at 2:30 today with Erika Christensen. She is an actress, and she's in my district in Hollywood now. And her mission on the Hill today is to promote the importance of substance abuse education, and to talk about it as a crime preventative tool, and the importance of treatment and front-end diversion as a way to reduce the recidivism rates of offenders who are already in the criminal justice system. I just asked my staff to see if we could locate her in the building now. She'll be here today and tomorrow, and see if she could come at the end of the second panel.
That would, without objection, that would be fine.
Thank you.
And Mr. Cummings, do you have any?
I do, yes. Mr. Chairman, I just want to pick up on where you left off. I live in the inner city of Baltimore, inner city, and have been there all my life. And I see a lot of young people who I have known since they were toddlers. Some of them, sadly, have grown up to be drug addicted. Others have gone on to college and done well. And I'm always curious as to how they got into it. And when I talked, and Dr. Volkow, when I was listening to what you was just saying a moment ago, you talked about the mental illness part, and I know that there's something called clinical depression, and I assume there are other kinds of depression too, but I noticed that a lot of these young people don't have a sense of hope. I'm just telling you. They don't, it's hard for them to see a future. A lot of the young women tell me that they got involved in drugs because of some young man. Trying to impress some guy, he talks him into it. Oh, it's just only take one time and you'll be fine. And the next thing you know, she's in pretty bad shape. There are, and then, and the thing that I guess that really gets me is how drugs can change a person drastically, from a person who may have been honest to someone who lies all the time, for someone who has never stolen anything to someone who will steal, from someone who never thought about harming another person to someone who will kill someone. I tell people quite often, while I love my neighborhood, quite often, most of the time I sleep better outside of my neighborhood than in my neighborhood, because I realize that a lot of the very young people that I watch grow up with, that'll say, "Oh, Mr. Cummings, how you doing?" show a lot of respect. Having been a criminal lawyer, I can tell you, I know that in certain circumstances, they could harm me. As a matter of fact, my predecessor, Perrin Mitchell, who was well respected, he was robbed at least 3 or 4 times, and we lived literally in the same neighborhood. So, and by the way, by the same young people that had a phenomenal amount of respect for him. And I guess my question goes to, is there, you talk about mental illness. We see people who spend thousands upon thousands of dollars every year to address mental illness. So we've got, but yet and still, it seems like not a lot with regard to mental illness is addressed when we give somebody a medication or whatever. Are we balancing that, or has our society come to even accept the fact that drug addiction is usually accompanied by some type of mental problem? And the reason why I started off the way I started off this question is because, you know, a lot of times people may have a problem, but it may not be classified as mental illness. Because I believe you can be so depressed over your circumstances that you don't even know you may have a mental problem. And so I'm just wondering, you know, I just want your reaction to that, and then that's all I want to. I'm finished.
Yes, and I think that that's absolutely correct. And indeed, one of the recommendations that we did as an agency was to start with, for example, young people that end up in the criminal justice system with a problem of drugs, that they be evaluated for the possibility that they may have a psychiatric disorder that has not been recognized. And indeed, on the recognition of mental illness in adolescence, where it's not full-blown as you see it in an adult, is not an easy thing to do. And so many kids go around feeling depressed with a learning disorder and taking drugs without realizing why they are doing it. So that is something that we can address. Then your second question, because that's a problem that we have in the country that should be taken care of, which is we basically separated, divorced the treatment of drug abuse from the treatment of mental illness. Right. I'm a psychiatrist. I was trained at New York University. I was not trained to deal with the substance abuse problems of my mentally ill patients, even though 85% of them suffers from some type of addiction behavior. So we've separated the care of substance abuse from that of mental illness rather than integrating, because guess what? It comes together in both directions. So if you take drugs, that may increase your vulnerability for a mental illness. If you have another mental illness like depression, that increases your vulnerability for substance use disorder. So this is something that we need to change, the way that we are providing for the education of psychiatry and the treatment of individuals with mental illness and or substance use disorders and or comorbid conditions.
And if I could just contribute, I want to answer as a scientist, and I want to answer as another guy who lives in the middle of a city, Philadelphia. And I don't want to leave the hearing with this kind of bleak idea that there's nothing we can do. Just the opposite, okay? But I'll tell you, if you're really asking, as I ask myself so often, how come I can't tell who's going to get this? How come I couldn't stop it? How come I couldn't help one of these young people that you're talking about? And I think science tells us something there. You have a role as a neighbor. You have a role as a parent. You have a role as a school teacher. You have a role as a policeman, a healthcare provider. None of those parts can do it by themselves, and that's what we've been trying to do for too long. One of the things we've seen in science, and one of the ways we're trying to correct it, is we want to stop, quite literally, buying prevention and treatment things that are just pieces of the real piece, of the real effective element. We want to bring prevention-prepared communities together, Baltimore, Philadelphia, everywhere, so where all the parts are working together. All the parts are able to see these kids, not just when they start to use, but as other problems start to emerge. And we can do that, and it's time that we do it. And the last thing I want to leave you with is another thing that's more hopeful and something we haven't talked about. Yes, these illnesses are devastating. They're terribly costly. They ruin lives. They ruin communities. But there's hope. There are 20 million people now that label themselves as being in stable recovery. More. So it is possible, and in fact, we think it's expectable. Treatment ought to lead to recovery, and it can. One of the reasons we're talking about medications and brain science and bringing all this together is with those new tools, we'll make that number 40 million and ultimately 60 million.
Thank you.
I don't want to leave the hearing with kind of, oh my God, there's nothing we can do. We can do things, and this is the time to do them.
Thank you, Mr. Kennedy. You had a...
I just want to thank both of you for the great work you do. My enthusiasm in questioning you is just to get my
Absolutely.
point across. I just
Sure.
can't thank you enough, Dr. McClellan, for the professional development, trying to get these state boards changed so we get more people in the healthcare field knowledgeable so they can diagnose and treat these illnesses. And Dr. Volkoff, your great work over the years in research has been so instrumental in moving it forward. I look forward to continuing to work with you. Thank you so much for your work, both of you.
Thank you very much, Mr. Kennedy, and members of the panel for participating in this discussion and hearing from our expert witnesses. This hearing is necessarily focused on what kinds of medication might be available based on years of research in neuroscience that would help people deal with their addictions. But I'm fully aware that there are other ways and other therapies that could be adjunctive and complementary. We have not really spent much time discussing them today, although our witnesses have acknowledged that they're looking at a broad spectrum approach towards addiction and not advocating just one approach. Because just one approach, if we're talking about drug therapy, would be admittedly a behaviorist approach that would be mechanistic. If we're talking only about genetics, it tends to be mechanistic. It's stimulus. We get into stimulus response psychology. We get into more of a behaviorist psychology than as opposed to humanistic psychology. We get into a neuropsychiatric model as opposed to something that maybe Menninger would have done years ago, looking at the bridge between science and religion, between physics and metaphysics, into looking at the potential of the human spirit for transformation. Because there's another element here that we really haven't probed at all. That gets out of the psychology of victimization. That goes to what happens when someone does take responsibility and maybe connects with spiritual principles in their own life that help them to transcend their dilemma. We didn't get into that today. But given this discussion, I think at some point this subcommittee will. I want to thank the witnesses, and we're now going to move to the next panel. Thank you very much.